Okay, great. Well, welcome everyone. Good afternoon and evening, and good morning, wherever you are in the world. It is so wonderful to welcome you to this really groundbreaking webinar. My name is Amy Cunningham, and I'm a co-founder and the global lead of World Eating Disorders Action Day, which was started 12 years ago by a group of parents and affected individuals related to eating disorders, of which I am both. I am both a person who suffered from anorexia starting probably almost 40 years ago, back when there really were no treatments at all that were evidence-based. And then just, luckily and with some great counselors was able to get some help and support. But what a shock when my youngest daughter developed anorexia. And as a parent, I was plunged into trying to save her life. I'm also a public health professional and trying to bring all these things together to really ensure that we have evidence-based care anywhere you are in the world. What's so amazing about this webinar is that it's really going to focus on culturally adapted, appropriate, evidence-based care in the Arab region and a pertinence for anyone in the Arab world, and also just has relevance for how all communities really need to make sure they have evidence-based care and treatment and information. Um, and then I want to let Dr. Carine Khazen introduce herself. Before we start, I'm just going to mention this webinar will be in two parts. We are recording, so this will be available to folks who can't join live. The first part are two amazing speakers, Dr. Carine Khazen from UAE in Lebanon right now, and I'll do a little bit more introduction in a second, and then Dr. Hala Abu Taha, and both of them will do a short, up to 30-minute, I think, presentation. After that, we have amazing panelists. We will introduce individually from Qatar, Jordan, Palestine, Kuwait, Egypt, Lebanon, and UAE, and we'll do a series of Q&A. If we have time, we can also take some questions from the audience. So really exciting webinar. So stay tuned. Dr. Carine, do you want to say a few words before we jump in?
First, I want to thank you, Amy, for starting this amazing initiative. Really, it's so important to all join forces and to speak up. At the same time, I guess the impact is louder. So thank you, and thank you for your courage, because as a mother and as an individual who has gone through this yourself, it takes a lot of courage also to come up and speak up. So thank you. You represent experts by experience, right? So individuals with lived experience, and it's very important to have you guys on board, because we are on the other side, and we can never really know what's happening inside our sufferer's head completely. So you are their voice, and thank you so much. And thank you for joining forces with our newly founded Arab Eating Disorders Association. And we're very happy, and we have some of the founding members with us here. So that's wonderful to have our first, I guess it's our first official event. So thank you very much. I can introduce myself, or you can introduce me. It's up to you.
I would love to introduce you. Please give me that honor to introduce you. I've just been so thrilled to work with you, Carine, over the years. From the time you all joined and you lit the purge, I was just amazed, and the power behind all of you, and in the region in which you are living and working, but also across the globe, particularly in underserved areas, Africa and other places. I lived more than 25 years on the African continent, so I am keenly aware. When my daughter got sick as well, we were in Tanzania, and I hope we have some of our Tanzanian reps on board too. But really, what you're doing is profoundly impactful. Even I'm in the United States now, even here, where you have underserved areas or underserved populations that need culturally appropriate treatment. So what you're doing where you are living is amazing, and it's having impact around the world. Okay, so without further ado, I would like to introduce our first speaker. So Dr. Carine Khazen is a clinical psychologist. She is a fellow of the Academy for Eating Disorders. She has over 20 years experience in mental health. She is also the founder and director of Eating Disorders Program at the American Center for Psychiatry and Neurology in Dubai. She is a CBTE therapist, a trainer, a supervisor, and the founder of the Arab Eating Disorders Association. And her work focuses on expanding access to evidence-based, culturally sensitive eating disorder care across the Arab world. So without further ado, over to you, Dr. Carine.
Thank you, Amy. Thank you for this kind introduction. So I'm going to talk to you today about, I'm going to give you an overview about eating disorders in the region. And then Hala Abu Taha, my colleague at the American Center, will talk to you about some of the things we've been thinking about to overcome the barriers that I'm going to be presenting today. There's so much work to be done, but I'm so glad that we're all together, and this is how we can make change happen. So let me see. So first, what is AIDA? So AIDA stemmed from the realization over 20 years of clinical practice of gaps of eating disorders, awareness, recognition, and treatment in the region. So something had to be done. And with like-minded professionals, also, to speak on a positive note, if we want to compare the state of the eating disorders field, when I started 20 years ago, we have progressed tremendously. Now we are many specialists in the region, not enough, but there are more. And there is a will to all come together to make a difference, because we all share the same experience and the same frustration when it comes to access to treatment and to offering the best available treatment to our patients. So our mission is obviously to advance the prevention. We want to train practitioners, first-line providers to identify eating disorders. We want to provide evidence-based treatment. We want to provide a culturally sensitive and adapted evidence-based treatment, and not Western-centric evidence-based treatment, because sometimes it's not suitable for our region. And the whole idea is basically to have a future where every individual, I mean, ideally, we wouldn't have anyone affected with eating disorders, but this is unrealistic. And especially the way, the world is progressing, I don't see this happening. But we have a role to play in terms of prevention. We have a role to play in terms of awareness, so that every individual affected by an eating disorder has access to the best possible care in our region. I mean, in the world, but we work where we are. And we are an underserved region, so our efforts are needed here. So if you have an idea of the eating disorder prevalence globally, it's around 9%. And we cannot, not stress how morbid or the level of morbidity of these disorders. They are the biggest killers in adolescents, so the number one reason of death, and the second one when it comes to adults. It was the first one, now it's opioid overdose and addiction. So the first reason of death is, unfortunately, medical complication, and the second one is suicide. So basically, eating disorders kill more than depression. So our context differs from the West. First, the religion is different. The majority of the region identifies as Muslim, and this shapes daily life, family, health behaviors. There are practices involved in Islam that are relevant for eating disorder sufferers, such as Ramadan fasting, veiling, body coverage, and the family roles differ. So in Europe or in the US, adolescents are adolescents until the age of 18, and then they leave the house and they're supposed to be independent. It's not the case in our region. Young adults live with their parents, and especially now more than even before, and the parents still have a role in the health-related behaviors, and we cannot not include them. And the language is also relevant, so our treatments are in English and also obviously developed for an English-speaking population. And language matters because subtleties of language, can make a difference. So it's also important to adapt these treatments in Arabic so that we can, provide treatment for also individuals that do not speak English. So when we talk about eating disorders, I like to go back to the basics. So the basics is that now we are lucky in the last 20 years, we have evidence-based treatments that work. And the recovery rates are significantly higher than with a treatment as usual. So talk therapy doesn't work. I have to stress that. It can provide some support. It can work for other mental health disorders, but not for eating disorders. Eating disorders require a specialized eating disorder treatments that are evidence-based, that have shown their efficacy, with multiple research, etc. So it's extremely important to get our sufferers to the correct or the appropriate, the effective treatment. So yes, there are a lot of very efficient treatments for other mental health disorders, but not for eating disorders. And then when you get to an evidence-based treatment, the problem is that, as I said earlier, they are Western-centric. So they are developed by and for the West, and they are in English. So these are two obstacles that we have as well. So they are prevalent. Now, we don't have a large-scale epidemiological study. However, we have multiple systematic review analysis. There are small cross-sectional studies, maybe with screening tools, unfortunately not, gold standard diagnostic interviews such as EDEQ and CIA. So our estimates are preliminary, but if you look at the numbers, they're quite striking. So if you think about the prevalence of eating disorders globally, it's between 1% to 4%. And if we base ourselves on, the meta-analysis that Bernou Melis did with her colleagues, and she reviewed basically all these small cross-sectional studies, the results she has or she came up with are significantly higher than those of the West. And here we have the risk of disordered eating. This is based on Melis's work. Bernou Melis is also a co-founder of AIDA. And she found that the risk also of disordered eating in our region is also significantly higher. So we cannot say anymore that eating disorders only affect the West. They are cross-cultural, and definitely in our region, they are highly prevalent. So they affect Arab individuals, men, females, all gender, and all sexual orientation, and all ethnicities. So why our regions might be even more prone to the risk of eating disorders? Because obviously, as you all know, we live in a region where there's a high level of conflict, PTSD, war, displacement. So there's a lot of trauma, or at least adverse experiences experienced by our population, which, as you know, eating disorders are coping mechanisms. So you are more at risk of developing an eating disorder if you have had an experience of a trauma in your life. What we've discovered recently in the last maybe 5 years is that food insecurity is also highly correlated to eating disorders. We thought before, initially, when eating disorders were conceptualized, that they only affected affluent individuals, and that people affected by scarcity and poverty were excluded. Now we know, and the data comes from the US and food banks, that it's the opposite. Actually, food insecurity represents a risk factor. And the most prevalent, it seems, eating disorder associated with food insecurity is bulimia. I can explain why later if anyone is interested. Obviously, we are immersed and bombarded by the diet culture and wellness, and we have cultural and religious norms that also are stressful. So you are someone from the Arab world, especially from a traditional family, is going to be exposed to dual pressures, and this creates stress. And again, eating disorders are coping mechanisms. So we know that they are prevalent here, and that we are even more at risk of having even a higher prevalence with our current situation. We have very, very few. So I was positive at the beginning of the talk. Obviously, we have more clinicians trained in evidence-based eating disorder treatment. However, specialized providers are scarce, And the majority of our patients, if they are getting to treatment, are receiving treatment as usual, or what we call talk therapy. We do not have a residential treatment center in the whole of the region. And in terms of higher level of care, usually our patients are hospitalized in either medical wards for medical stabilization or generic inpatient psychiatric services, which unfortunately can even trigger more eating disorders behavior. On the positive note, at UBMC now, and Jumana, we can discuss this later, they do provide CBTE for inpatient patients, basically. So this is a good first step. But again, UBMC is in Beirut, and you have Lebanon, you have a lot of regions, a lot of areas in Lebanon that are far from Beirut, and they cannot have access, and it's expensive. So there are still a lot of barriers. So just to summarize, we don't have eating disorder centers. Most patients get to talk therapy. We have few trained clinicians, and in general, the care is delayed. So our big challenge is stigma, especially in the Arab world, and especially for males. There's a high level of stigma because eating disorders are, food issues. They're not supposed to be, they're not recognized as mental health, life-threatening illnesses. And we need to adapt treatment. We have social cultural factors that even represent a bigger barrier, and we have obviously systemic barriers. So as I said, eating disorders are not recognized as serious mental health illnesses, not only by sufferers, but most importantly by policymakers and providers. As you know, because the situation in our region is so turbulent, the priority goes to basically providing care, if any, to PTSD or refugees, like general mental health support. And there is really nothing that is dedicated to eating disorder. And a lot of the population, if not the majority, does not even know that evidence-based treatments exist. So for them, if eating disorders are recognized and if a referral is being made, basically, usually it goes to your, generic psychologist who is going to basically, provide just talk therapy. Okay, it seems the meeting has been locked, and so let me 1 second. See
Yes,
what's
Carine,
happening.
because a lot of people are asking to have access to the meeting again.
Okay.
They're not able to join.
So is it okay? Let's see now. If it's working. Yes. Okay, it should be okay now. So I'm going to basically share my screen again.
Well, it's great to have so many people join us, though.
Yeah.
I see people coming in from Tanzania, from other continents. That's awesome.
That's wonderful. So going back to our talk, so I don't know what's happening. It's here. We have a high level of weight stigma, again, I think everywhere in the world, but in our region, even probably more. Individuals in higher bodies are completely dismissed, and if anything, prescribed eating disorders. Weight loss is always glorified, even if it's basically covering an eating disorder. And this obviously leads to delayed care. And even individuals in larger bodies do not think that they could have an eating disorder. So this is where we are in terms of awareness and prevention. We need to adapt our treatments, and Hala will discuss this. We need to talk about fasting during Ramadan. We need to adapt our body image work. For example, in CBTE, there's a lot of body image work that can be difficult with veiled women. So we need adaptation. We need psychoeducation that reflects the local beliefs and culture. And obviously, eventually, what we need is to expand delivery of evidence-based treatment to remote areas. Because again, we are still all all of us, all the panelists are basically located in urban cities, right? Like in big cities, but sufferers are everywhere, and a lot of them cannot commute and come to us. So this is also something that's very important to think of. We cannot just offer treatment to those who can afford it also. So a lot of insurances do not cover eating disorder treatment. Our services are expensive. So this is another problem. So obviously we have, when we think about future directions, we need to work on the systemic part and the clinical part. So we need to have actual data because we need to use this data to influence policymakers. So if we can prove that they are prevalent, not just from cross-sectional studies, but from actual big studies, then we can maybe use this to influence policymakers. We can influence insurances to cover eating disorders. We can get governments to train providers and things like that. And this is where IDA has a role, I believe. Clinical, we definitely need to expand clinician training in evidence-based treatment. We need to adapt our treatments to make them culturally sensitive. We need, as I said, to work on accessibility and affordability of these trainings, not only of the treatment, because a lot of clinicians would like to get trained, but also trainings are costly. So this is another barriers. And we need to establish MDT teams, not only one in Lebanon and us all, outpatient in our countries. There need to be more. It's great that we have today more resources, but we are far from what we need. So what I want to say is that change is possible. So we have a very, very, not big, but we cater to a lot of patients at the American Center for Psychiatry and Neurology. We have an MDT, and we're all specialized in CBTE. Now UBMC as well, Sidra Medicine, they all have CBTE programs. And now we are providing CBTE trainings, which are accredited by Credo, so the center who has developed CBTE, and we have adapted CBTE for the Arab region, and we hope that this will, pave the way to get treatment, to get more sufferers to treatment. So yeah, change is possible, and this is why we're here today. Thank you very much.
Thank you so much, Carina. That was such a really powerful presentation. Yes, thanks. Let's give Dr. Carina a reaction. Thumbs up.
Thank you.
Yay, some hearts coming
Thank you
in.
very much.
Awesome.
Thank you.
Thank you. And for those
you.
of you who may have joined, oh, I love that. We just have to use our virtual as much as we can to give support. For those of you who may have joined later, had a little trouble joining, thank you so much for joining. We are going to be saving the webinar and posting online, and we'll cut it into different pieces so you can see all the different sections.
Mm-hmm.
But I think right now we're going to move to our second speaker. And did you want to do the introduction, Carina? Or did you want me to?
If you want, I can, definitely.
Or I can.
Okay.
I'm happy to as well. And then we'll move into the, no problem. We'll give you a second to catch your breath as well after that fabulous presentation. Okay, wonderful. Well, our next speaker is Dr. Hala Abu Taha, coming from Jordan. Dr. Hala Abu Taha is a clinical nutritionist and eating disorder specialist with over 20 years of experience. She holds a BSc in Clinical Nutrition and Dietetics from Hashemite University, Jordan, and a master's degree in Psychological Medicine from the London Metropolitan University. Hala has extensive experience supporting individuals with eating disorders, including anorexia nervosa, bulimia nervosa, binge eating disorder, and ARFID, with multidisciplinary treatment teams in the UAE. She is CBT trained, experienced in CBT-AR for pediatric feeding disorders, and has delivered professional training across the UAE and Lebanon. Hala has also presented at the International Conference on Eating Disorders, ICED, and is an active member of the Arab Eating Disorders Association. So without further ado, over to you, Dr. Abu Taha.
Thank you, Amy, for this great introduction. I'm glad I'm here. Just let me try to share.
And you're getting a lot of love from the audience.
Yeah, actually. So can I guarantee the access, please, Carina, to share?
I did.
You did?
Yes.
Okay, here we go. Okay. Can you see it now?
We can see it now. It looks great.
Yep. Okay, so today my talk is about the cultural adaptation of eating disorders treatment for the Arab population. And I'm honored and glad that Carine worked on basically creating this adaptation through this last 12 years we worked together. Some aspects were challenging at the beginning, but like working together in this environment, and each has our different backgrounds, helped a lot. So we of course automatically we know that it's really challenging to hear what you want to recover, but you hear still different examples, different messages different than the culture that you're used to. So we found that it's going to be so challenging to push through this recovery when the evidence-based treatment is not basically designed as same as the cultural background. However, the main pillars for both eating this evidence-based treatment that is delivered there and the original one is the same. So it's basically the adaptation did not change any of the pillar or the core treatment, and it was only flexible and adapted to fit in a good pathway of recovery. So we're going to talk today about the introduction of CBTE, Cognitive Behavioral Therapy Enhanced, main elements affecting the treatment of the CBTE on the Middle East population, Ramadan, Aura or body coverage, cultural adaptation of earth surfing techniques to the East population, and additional consideration. So before it was so known that eating disorder is more into a Western disorder, but studies showed that is nothing Western about it. It's mainly, it can be common and it's rising all around the world. So here are some, in this graph, it shows that the difference between the global clinical ED and the global Arab world, the high risk binge eating disorder in the West and the high risk of binge eating disorder in the Arab world. So we can see now it is common and it's rising even in the Arab world. And this is Bernou, our colleague, has also published a very nice article about this. So talking more about the CBTE, which is the Enhanced Cognitive Behavior Therapy. It originally was developed by Dr. Christopher Fairbairn and colleagues at the University of Oxford in UK in the early 2000s. It was developed to treat bulimia nervosa, and then it was adapted to all the eating disorders. So it is the gold standard treatment for adults with eating disorder. And it is now, it was adapted by Dr. Ricardo, and it is recommended for adolescents with, of course, the adaptation and family involvement if needed. So it is the transdiagnostic treatment used for across the anorexia, bulimia, binge eating, bulimia nervosa, and other EDs is all addressed and tackled in the CBTE. So it gets usually delivered in two forms. The first form is the focused form, which is CBTEF, and it is the default form. And there is also the broad form, which is the TBT-EB, which is it incorporates additional maintaining mechanisms. Typically, the manual was designed for 20 sessions for non-underweight patients, and up to 40 sessions patients with low body weight, so whether it's underweight or suppressed weight patients. So targets the core psychopathology, which is, as we all know, the overvaluation of weight, overvaluation of shape, and the overvaluation for control, food control per se. So the core principle of CBTE, it's structured, time-limited treatment delivered in 4 stages. And this is the beauty of the treatment. It's not eclectic, it is so structured. So the stage 1 usually, and by the way, it's very important for me to highlight that CBTE is usually delivered by the therapist, by not only any therapist, by an eating disorder and CBTE trained specialist. So and it was developed and it was to be delivered by one therapist. However, now Dr. Ricardo and in our center, we develop it as a multidisciplinary team, but also the therapist is the leader or who leads the treatment. So it is the stage 1 is starting well, where we focus on the engagement and the formulation, which basically make the patient understand the relations and the reality of the eating disorder and how it connects to the thoughts, establishing the regular eating, which we're going to talk about a lot later, and we address in this the starting well, address the early change mechanism. Stage 2, basically, it's a revision, it's a review to evaluate the progress and plan the rest of the treatment. What exactly we should plan? Stage 3, we address usually the maintaining mechanisms, which has 4 modules. The first module is body image module, dietary restraint, event and mood and eating, and setbacks and mindsets. Then stage 3 is ending well, where we consolidate the changes and relapse prevention. So this is the map, which is it's so clear map, where here again stage 1 is 1 to 7 sessions, and stage 2 until stage 4 ending well. So in Islam and in this part of the world, this culture, the 2 of Islam essentials relevant to our population, which means in Islam shapes daily practices, including eating patterns, body-related norms, which are relevant in understanding eating disorders in this population. So, for example, fasting, which is Sawm, and whether it's Ramadan or Ramadan, but commonly Ramadan, Ramadan is one of the main pillars of Islam is fasting. So Ramadan is mandatory. So there is a difference between mandatory and there is sunnah. Sunnah is what extra our Prophet Muhammad has done. So we follow this sunnah just to extra bonus, kind of, which is the Mondays and Thursdays of each week. And this is completely optional, but Ramadan is mandatory. And the other aspect would be related to our population is the body coverage, which is awra. Women's awra in Islam is the whole body that can cause lust from head to toe, which must be covered with clothes that can cover them, except for the face and the hands or the palms of the hands. The garment should be loose so that it does not reveal, and the slice posture or body curves cover the entire surface of the skin without being adorned and colored, and cover the entire body from head to feet. So basically it should be covering as much as possible and less attractive, I can say. So Ramadan and the role of fasting in the eating disorder. Let's talk more about Ramadan. Ramadan, it's a structured fasting and eating in windows. That means it can disrupt regular eating patterns. As we said, that it's an important recovery tool within CBTE. It's prolonged restriction, which mainly is going to increase biological and psychological vulnerability. Iftar exposure will be risk of loss of control, because imagine that we fast 17 to 19 hours, and then suddenly we break our fast and iftar. So this exposure can put the patient at risk for loss of control or binge. And Ramadan and fasting also may mask or legitimize restrictive behavior, which is like restricting with the license. So don't talk to me. I'm not restricting for my eating disorder. I'm just fasting Ramadan. It may reinforce rigid restraints and eating disorder cognition. Fasting may increase medical risk. And here where I want to say, not most of the time, not may, it will affect, it will increase medical risks like dehydration, especially now it was in summer, electrolyte imbalance, especially in undernourished patients. So not about blame. Choosing not to fast can support recovery and faith, and here where we made it so clear to our patients throughout our recovery journey. So the regular eating procedures during the holy month of Ramadan, how does it affect and how we addressed it? So meals during Ramadan, there are two main meals, which is futur and suhoor. Futur is the one we break our fast after sunset, and suhoor is the last meal that we have. It's exactly before the sunrise, which is Maghrib and Fajr. Involves food and water abstinence for 17 to 19 hours at a time, which can be different zones, different duration, and of course, different seasons based on the month of the year. So the break of the fast, which is futur, usually involves exposure and consumption of very large amount of food. Very minor family, like there are very few family that can be moderate and they don't overdo it. It's now, unfortunately, it became about just more showing off or more cooking, and it's all about cooking the many items in at futur time. So it's already a medical and psychological stretch for the average Muslim. So when it comes here to regular eating, which is in CBTE map, the therapists usually establish it in the stage 1. The regular eating intervention in CBTE, it's introduced, as I said before, early in treatment in stage 1. Forms the foundation for all later treatment steps. We always say that the irregular eating is not a diet. It is a therapeutic tool that basically it's a pillar. Eating this CBTE cannot be without regular eating. Used across both pathways. So for low body weight or for non-underweight, bulimia nervosa and binge eating, and for low body weight or underweight, anorexia nervosa. So what is regular eating specifically? It is structured pattern of 3 main meals, 2 to 3 snacks daily, eating every 3 to 4 hours, not more. The maximum gap should be 3 to 4 hours and nothing in between. So regular eating has 2 elements: eating at regular intervals during the day, which makes the patient feel the real control, sense of control, and not eating between the gaps. So why it matters actually? So in bulimia nervosa and binge eating disorder, it reduces immediately the binge eating quickly. Like we see it like a miracle. The minute we establish regular eating, most of our patients will come for the week after and say, oh, I didn't binge this week. And for underweight patients, it restores nutritional intake and normalizes physiology, which we can see significant improvement in the medical instability only when we start the regular eating. So why is regular eating intervention again important? Because it addresses maintaining factors of eating disorder. If we think about it, as we said before, patients with eating disorder, they eat in irregular basis. So eating irregular pattern maintain eating disorders by perpetuating hunger, emptiness, preoccupation with food, and emotional dysregulation. So regular eating directly target these factors. And then the second one is foundation for further progress because cognitively patients need to be more aware. So whenever their blood sugar is stable, they are well fed, they will be it lays the groundwork for other CBT interventions. So promotes recovery and prevent relapse, which regular eating helps patients rebuild a healthier relationship with food and their bodies, significantly contributing to long-term recovery, which mainly the hunger and fullness cues and too many other factors. So how does it difficult to maintain eating disorder, regular eating during religious fasting? First of all, of course, the disruption of regular eating. So fasting conflicts with structured regular eating patterns. So because we have a very prolonged a period of fasting, so this can prolong the restriction, which increase the risk of binge eating and loss of control. The other one, of course, is the reinforcement of eating disorder maintaining mechanisms, which is restriction, because the more they restrict, the more they maintain their eating disorder. The preoccupation with food, the more they are preoccupied with food, the more they want to restrict. Irregular eating maintain the disorder core intervention. So that's why regular eating become too difficult to implement. Increased psychological and behavioral risk, heightened food focus. I always tell my patients, when I fast, I will be always thinking about food, preoccupied. So I understand even if I'm not underweight, how fasting for long hours will make me preoccupied. So heightened food focus. Restriction, binge episode during non-fasting periods may undermine treatment progress. Physical and emotional impact, of course, fatigue, irritability, reduced concentration. This all can impair engagement in therapy and skill use. So exemption of fasting and eating disorder in Islam, especially in Quran in Surah Al-Baqarah, Allah mentioned that some people can be exempted from fasting. So in Islam, individuals who are ill are exempt from fasting. This includes eating disorders as both mental and physical health condition. Clinical and religious alignment, of course. So the treatment team assess risk to medical and psychological well-being. That's why we need to put the same weight for mental health as physiological health. So it's going to be also affecting the mental health. So Islam does take into consideration that. If fasting is harmful, patients are exempt definitely and can engage in alternative act of worship. Religious guidance, religious authorities, Dar al-Ifta, and we in AIDA have approached the Dar al-Ifta and asked them about it, and they confirmed that mental health that can affect the physical health is a reason why patient can be exempted from fasting. So they do permit the break the fast. So patients are encouraged to seek guidance from their medical team, of course, therapist, and of course, religious authorities if needed. So can CBTE be modified to accommodate religious fasting? Yes. In certain cases, CBT can be adapted to respect the patient's religious practices while still aiming to support their recovery. However, it should be agreed with the therapist and with the medical doctor. Some cases they are forbidden to fast. So rarely in some cases they will be allowed, but definitely with some assistance, and it has been adapted in CBTE. So planning around fasting windows, work with the patients to establish a structured eating plan within the allowed eating hours, iftar and sunset, after sunset and before sunrise. So ensure meals and snacks are all balanced, and this sometimes dietitian and most of the times us as dietitians, we help the patient thoroughly to plan balanced meals that can help them reduce any harm and include sufficient energy. Post-fasting recovery, If fasting is temporary, which is during Ramadan, focus on maintaining progress in other areas or other aspects of the treatment and resume the regular eating strategy immediately after the fasting period ends. Sometimes we manage to convince them that they don't fast every day. Maybe they can alternate one day yes, one day no. And collaboration with religious leader or community. If appropriate, involve religious leaders or community supports to explore ways to patients can participate in their faith while prioritizing, of course, their health and recovery. So alternatives to fasting, the therapists usually teach patients to many things. Fasting is not the only way to engage uh, spiritually during Ramadan. Alternatives include prayer, charity, kindness, Quran reading can be also a very good alternative. Postponed fasting, because in Islam we can make up for the days that we didn't fast later. Missed days can be made up and can be done shorter days throughout the year, especially in winter, guided by medical advice. Now, obstacle to abstaining from fasting, feeling of guilt, of course, because why everyone else is maybe I will be not a good Muslim, social stigma, and this is horrible because they can be scrutinized by others, or fear of missing out all this like gatherings or all this praising from others that they fast, fear of rejection from the community, of course the misconception in the community, which basically it is eating disorder cannot be a Muslim problem, which is never the case. And of course, because they have lack of understanding of this eating disorders. And this is our job or our role to raise the awareness. So role of the families can play a huge and amazing role here. Families should be educated about the impact of fasting on eating disorders, and their support is essential in helping their loved one make informed decisions about fasting. So how can we engage families? We actively involve and educate, clarify religious exemptions and alternatives to fasting, encourage support for regular eating and recovery, guide families to reduce pressure and avoid triggering, which protect them from the extended family or friends, promote inclusion without requiring fasting. Key message: family can be mobilized as powerful allies in recovery. So, covering the body in Muslim veiled female patients, which this is usually done completely by the therapist, which is the body image module. Like we said, it's that on the stage 3. So body image is in the stage 3. It targets the overvaluation of weight and shape and the core underlying psychopathology of eating disorder. How does it maintain the eating disorder? Of course, the self-worth becomes overly dependent on weight and shape. Nothing can boost the self-esteem more than the body shape and weight. And that's why it's called also body image, because this is how they imagine themselves. So leads to the more they worth and the more they feel that their worth, their worth is related to body image, the more they want to do dietary restraints, which increases the risk of binge eating. The more they want to do body checking and avoidance, which reinforces the negative beliefs. The more they avoid, the more they will think negatively, and the preoccupation with appearance, which maintains.
Hadid,
So results creates a self-perpetuating cycles of restriction, binging, and dissatisfaction. And goal of the module basically to reduce the importance of weight and shape in self-evaluation, break the link between body image, disordered behaviors. So the therapist mainly works on other area to or mechanisms to self-value. Covering the body for awra, women in Islam are requested to cover, as we mentioned, their whole bodies except the face and hands. So, as we said, the garment should be loose, cover enter everything, the surface, the skin, and cover the body from head to feet. So, baggy and loose clothes can play a role maintaining the eating disorder. How? And this is so important because it can be a way to hide patients irrationally perceived negative body image, body avoidance. They do wear like baggy clothes and then they avoid seeing their body or showing others their body. In anorexic patient, it can be a way to hide weight loss also, and this is so common. So target body avoidance, a key maintaining behavior. What is body exposure? Gradual, repeated exposure to one's body to reduce the stress and negative beliefs. So the more they are exposed, the less they have negative beliefs. How can they get the exposure? Mirror, wearing less concealing or avoided clothing, focusing on avoided body areas, cultural consideration, some standard exposure tasks, يعني revealing clothes may conflict with norms of modesty and requires culturally sensitive adaptation while preserving the therapeutic principles. Key message, core CBTE model should remain unchanged, and this exposure should be there, and it was created by Carine in a very nice way, Carine and the team. Adaptation is needed at the level of specific exposure tasks. Impact without addressing avoidance, body image concerns remain a maintaining factor. So where is the difficulty with body exposure exercises? The challenge is the body image module in CBTE typically include exposure based exercises such mirror work, wearing fitted clothes, swimsuits, exposing specific parts to confront and reframe the negative body image thoughts. So without these exercises, it may be more difficult to address body avoidance. And again, because of the modesty and the cultural sensitivity, this can be tricky. So also the limited visual exposure to their own body, which veiled women have limited opportunities, of course, to see their bodies in clothes, only with females or at home with men from their own blood, which we call it mahram, reducing opportunities to evaluate their body realistically, of course. So the impact, this can be harder even, make it harder to challenge distorted body image beliefs because the individual may rely heavily on imagined and not real or exaggerated perceptions of their body size or shape. So the greater emphasis on internal feelings about the body and difficulty, which is the feeling of fatness, I feel fat, I feel big, the feeling, which is for veiled women, body image concerns may focus more on how they feel about their body. I feel fat, I feel unattractive, I feel ugly, I feel big, rather than how they look to others. Impact, this can complicate the therapeutic process because it requires a great focus on addressing internalized feelings rather than observable distortions. So another challenge, which is are they doing it for religious purposes or eating disorder practice, like exactly fasting? So potential confusion between religious practices and eating disorder symptoms. Body covering can sometimes overlap with eating disorder related concerns, such as using loose clothing, hiding the weight to hide the weight, and basically to avoid. So differentiating between cultural and religious practices and distorted behavior is essential, and it can be so complex and so sensitive. So therapists should be so aware of this thin line between both. So how to navigate these complications in CBT? Avoidance of matter use can be addressed through private, of course, female alone or where their maharim, gradual exposure when the patient is alone. Exposure to fitted or revealing clothes can be practiced at home or all female social gatherings, which is so common here. Where the patient feels safe, and halal. Beach exposure may be approached by using bikinis, which is the full modest swimsuits, and also in our part of in UAE and other parts, there is female only beaches or clubs that they also can try this. Veeling at home in the presence of close family members is uncommon. If observed, it may indicate heightened body image of course concerns or possible weight loss, particularly in underweight patient. Now, use religious practices for, as we said, event, mood, and eating module, which is the earth surfing. Earth surfing event, mood, and eating module introduced during, again, stage 2 to 3, target urges to binge, purge, engage in eating disorder behaviors. So what is exactly urge surfing? As most of you already know, learning to observe urges without acting on them. Understanding that urges rise, peak, and pass. So how does it work? We usually therapists and we teach patients to notice the urge, thoughts, emotions, physical sensation, pause and delay action, not to act immediately, and let the urge pass naturally without responding to it. So the key message here, urges are temporary and tolerable. They'll go, eventually they'll go. Acting on them is not necessary and might also increase the maintaining mechanisms. Culture integration can be supported through religious, spiritual practices, prayer, grounding, reflection, in addition to other things, and reinforces values of patience and self-regulation. So here, when it comes to religious practices as urge surfing techniques, using religious or spiritual practice during urge surfing is optional, of course, and can complement more commonly used techniques for patients who find it meaningful. Not everyone. For some individuals, especially in the early stages of urge surfing, engaging in prayer, extra prayer during the urge may feel too challenging because they cannot concentrate or focus on the purpose. Others may find that spiritual connection provides strength and comfort, helping them better manage urges. So it's pure. Therapists can help patients recognize that. So the urge surfing techniques can be used when practice Islam in Islam when patients practice Islam. So wudu, which is ablution. So this where we use water to wash ourselves in a specific way. More prayers, which is nawafil, extra. In Ramadan, it can be Taraweeh, which in Ramadan specifically, there's a prayer called Taraweeh. We pray more extra 20 at night, rak'ah, and use of rosary, which is masbaha, to connect more with and mentioning Allah, God. So this can be sometimes one of the good way to serve the urge. So also reading Quran can be reading hadith, which is the Prophet Muhammad words, and reading afkar, which is more like praying extra for Allah. So additional consideration, this was also done by Carine and team, and which is you can see it here. It's the EDEQ validation in Arabic, adaptation CBTE Middle East, also, and validation of culturally adapted CBTE protocol in the Middle East. Actually, now it was published, not in progress. Sorry. Thank you.
Thank you, Hala. It was wonderful.
I tried as much as possible to finish in 30 minutes, and I did.
Yes, yes,
Yes.
amazing, amazing, amazing. Thank you so
Thank
much,
you.
Hala. It was so clear and at the same time, structured, clear and structured. So thank you so much. There is one more adaptation that we do, but we don't have time to talk about everything today, is family involvement. So also if the audience has questions about that, we can definitely answer. But I guess now we are going to present our panelists. We're going to ask them questions. And also, we're happy to take questions from the audience to Hala and myself, and to the panelists, and to Amy, obviously, who's a very precious expert by experience and can give us, her take on all of this. And also living in Tanzania and being in an underserved region is also something that you can relate to, I'm sure, Amy. We are Fariha. Fariha, thank you for your question. Fariha, you can put. First of all, I'm going to ask the participants to mute themselves, if possible, kindly and respectfully. Thank you. And if you have questions, please put them on the chat, and Amy and myself will go through them after the panelists. So I'm going to leave Amy to introduce. I'm going to let Amy introduce our first 3 panelists, and then I will take over, and then Amy will start with the questions, if you don't mind.
Thank you so much, Carine. Thank you so much, Dr. Hala. I actually was really touched by your presentation, especially the way it was laid out in the beginning. And I'm sure we're going to hear about this from panelists a bit too. And just as a parent and a person with lived experience, it may take a year to get past phase one. And what we always say in the family circles, even as you as therapists wrap in other phases, it's a marathon, not a sprint.
So we need to pace
Um,
ourselves.
you do really have to, it's a lot of patience, a lot of persistence, and it's not linear always, but so wonderful that you all have laid this out, and the way you presented it was so nice. And these important cultural considerations are so important. Okay, so as Dr. Carine said, I'm going to introduce the first three panelists, and then Carine will introduce the other two, and then we'll jump into some questions. And we'll also reserve some time at the end for questions from the audience. So please, if you're thinking of things, if you feel like writing them down in the chat, if we can't get to everything, I think we can find a way to be able to give some feedback as well through social media and share some of these responses. So first, we are so lucky to have Miss Tana Habib from Egypt. She's a clinical psychologist, eating disorder specialist, and associate nutritionist from Egypt. She previously led an inpatient eating disorders program in Egypt and currently provides evidence-based treatment for eating disorders across multiple private clinics. We have Dr. Ayman. I'm sorry if I'm pronouncing your name wrong. You can help me with that. Ayman
Iman,
Abalouche.
Iman.
Iman. Thank you, Iman Abalouche from Kuwait, who is a consultant, child and adolescent psychiatrist from Kuwait with areas of interest in ADHD, eating disorders, addiction, and trauma. You're currently working in child and adolescent psychology, the child and adolescent psychiatry clinic in the Amiri Hospital, in addition to addiction treatment center focusing on adolescent substance abuse. And then we also are so lucky to have Dr. Madiha Kamal from Kuwait. Dr. Kamal is a senior attending pediatrician at the Sidra Medicine Clinic and a professor of pediatrics at Qatar University, as well as an associate. Oops, sorry.
We have a
I have a
baby.
little hot mic there. Associate professor at Weill Cornell. She trained in Canada. She's American and Canadian board certified and is a member of the AAP and Canadian Pediatric Society. She leads adolescent medicine at Sidra, where she established the adolescent program in 2013. Over to you, Carine.
So I'm very happy to present my friend and colleague, Mrs. Jumana Ammar from Lebanon, from UBMC. She's a licensed clinical psychologist, and she heads the eating disorder program at the American University of Beirut Medical Center, AUBMC, where, as I said, they can provide CBT inpatient for inpatient. She's a co-founding board member of AIDA, and she's recently, she's the president of the Lebanese Psychological Association. So congratulations, Jumana, on also this important position. And I'm especially happy and grateful for Ms. Zaina Barghouti that is joining us from Palestine, from Ramallah. So I'm very happy that she was able to be with us. She's a clinical nutrition and eating disorder specialist. She's the founder and owner of Zaina Nutrition Wellness Clinic. She has an MSc in clinic nutrition and eating disorder from UCL London and a Bachelor of Science in Nutrition with Food Consumer Science from the University of Reading. And she's an ex-lecturer in Birzeit University. I don't know if I said it correctly. Thank you, Zaina. I'm very especially grateful that we have Palestine on the panel. It's so important.
Thank you for the introduction. Thank you so much.
Seconded that. Thank you so much, Zaina. We're so happy to have you here. Well, we're going to jump right in, everyone. So we're going to ask each panelist, and maybe we'll start with you, Zaina. In one sentence, what is the biggest challenge facing eating disorders care in your country today?
So first, thank you so much for introducing me and for being part of this lecture. What I can say is the under-recognition of what are eating disorders in their nature, because eating disorders are a complicated mental issue, and unfortunately still in our culture, it's perceived as just associated with thinness with only the look of being thin without knowing exactly that it has underlying conditions that is manifested through disordered eating behaviors. So there is under recognition, lack of awareness what are eating disorders exactly, and unfortunately associating it with one concept, which is the thinness. That's why it's getting later diagnosed, especially people are getting late or delayed diagnosis, which obviously will complicate the issue. So that's a major challenge that I'm facing right now.
Very, very important. Yes, and we know that earliest diagnosis and earliest intervention is the most critical need right now to get people in treatment and have the best outcome. Oh, thank you for that. We'll go next to sorry, I'm scrolling around to Miss Habib. Over to you.
Okay,
What is the
I
number one
think,
challenge you're facing?
yeah, I think simply put, our greatest challenge is the gap mainly between the number of people who are actually suffering and the number of people who are identified and then receive the appropriate care.
Thank you. Thank you. Jumana, please, to you.
So I think it's similar to what Hannah was saying. I think the demand in Lebanon is rising faster than we have access to treatment, and it's one of the biggest challenges right now. There's a rise in eating disorder patients, and at the same time, we don't have many specialists, and the specialists that are available are concentrated basically in Beirut mostly. So people from further areas in the south and the north don't really necessarily have access to care.
So critical, finding ways that we can deliver care even where there's no immediate access.
Right.
Yeah, I hope we can hear a little bit about how you all are facing these challenges as well. Dr. Ayman, over to you.
Similar problems, increasing demands and very, very limited resources. And I think people who are in Kuwait who are interested in this field, maybe you can count them in one finger or one hand, or maybe less than two hands. So so this is a similar problem. Also, some people find it intimidating as a field and very difficult. That's one part of having lack of experts in that field. They feel they are very challenging, they have poor prognosis, and even some experts in mental health, they wouldn't specialize in that field because of these concepts.
That actually is really, really interesting, I think, in terms of both like not the lack of providers and trained providers, but also perhaps fear of the providers since it is a difficult area to tackle. Thank you for raising that. Dr. Kamal Madiha, what is your thought about the most challenging issue in your country?
So I would agree with everyone else. I would support that. So early identification is a problem because a lot of people normalize that thinness, exactly what others said, and a lack of resources, because even if we did introduce awareness programs, and then we got the influx of patients, where are the resources to meet that influx? So this is the most challenging thing.
Right, exactly. And that's one thing as folks who are involved both in the awareness raising side of it globally, it's become very, very clear that as you raise awareness, great, but what are you going to do with the folks who show up? We really need to have those trained providers and those services. So it's a little bit of a double-edged sword. Thanks. Those are all really, really powerful issues. Over to you, Carine.
We still have to hear from Dima from Jordan.
I'm sorry.
Dima Kilani. Dima, yes, Dima is a
Dima,
clinical
please.
dietitian.
I'm sorry. I
A
didn't mean to
clinical
miss you, Dima.
dietitian and
No
eating
worries.
disorders specialist. She has a master in dietetic eating disorders and obesity. She has, from the UK, completed many specialized courses in the field of eating disorders, including CBT-AR, CBTE, and informed FBT. And she's an anti-stigma activist. So
Yes.
we're
We
happy to
love
have you,
that.
Dima.
Thank you,
Regarding
Dima.
the biggest challenge in eating disorders in Jordan, actually the lack of awareness among both general public and healthcare professionals, unfortunately, including physicians, psychiatrists, psychologists, and also dietitians, many of whom have limited knowledge of the signs of eating disorders, the assessment, and the treatment actually of eating disorders. Many psychiatrists, psychologists, they even don't know about CBTE or FBT for eating disorders.
Thank you for raising that. And sorry you were at the bottom of my page here. I apologize.
No worries at all.
And underscoring one thing you mentioned around this is educating families who are actually doing so much of that work at home, and they can be a real barrier if they're not on board. So
Yes.
yeah, there's a lot of education that we need to be doing. Okay, now I think I'll hand over to you, Carine, for the next question.
Yes, so my next question is, I'm interested to hear from you. What are the new presentations that you are seeing? Are there any emerging trends? Like, are the presentations of eating disorder sufferers changing now over the years, especially for those of you who have been working in the field for some years? And then we can share also from the UAE what we've been seeing. So maybe Zaina, you want to start?
Yes, so let's say the last year or so, the major presentations that I'm seeing that are related to eating disorders are more of restrictive habits, which restricting eating habits, which is augmenting the eating disorders complicated nature, as well as the emotional eating, which technically is related indirectly to the eating disorders nature. So with the situation, with the overall environment that the patient is suffering, it's more of the emotional eating, the restrictive eating habits mainly, and the body image. So it's like more with social media and with the uprising of the social media pressure. I think what I'm seeing mainly is the body image concerns, which are leading actually to the complicated eating or disordered eating habits that we're saying. So mainly, but with body image, emotional eating, and the restrictive eating habits that are related all to the eating disorders nature are being more prevalent. That's what I'm actually realizing the last few months or year.
Thank you, Zaina. Jumana, maybe you can tell me a bit if you're seeing an increase in, for example, children consulting for typical eating disorders. So, for example, when I started, we never saw a patient below age 14. Now we see patients who are 11 or 10 presenting with typical eating disorders. Are you seeing gym goers, boys who are, becoming, as we say, bigorexic? Are you seeing more orthorexia? I mean, you've been heading this program for, I think, 2 years, Rumana. So have you seen any changes?
Yes, and I think the first thing that you mentioned, the age of onset. So we've had to hospitalize over the past few months. I've had two 10-year-olds, an 11-year-old, a 12-year-old with significant medical issues, medical complications due to their weight loss. So this is something we didn't used to see before. So even though I wasn't heading the program before, I've been in the department for the past 14 years, and we haven't really had an admission to the hospital at such a young age. And in my clinic, those who don't have as severe medical presentations, I'm also seeing a lot of preteens who are over-exercising, restricting their diets, consulting ChatGPT on their diet plans, and really following a plan of 500 to 800 calories per day, increasingly obsessing about how many proteins they're taking, how many steps they're putting
Macros.
in. Exactly. And I am seeing more boys recently, but I haven't seen anyone with bigorexia, but mostly anorexic boys. I've had a few over the past few months, and the complexity of the cases and the severity is increased. So we have a lot of comorbidities. We're living under like chronic stress in Lebanon. We have recurrent wars. We have a financial collapse, and I think all of that is really impacting people, and we're under constant stress. And a lot of people cope through eating, and it's showing a lot of eating disorders behaviors. And also, I'm seeing a lot of disordered eating patterns emerging within groups of friends. So I've had many people tell me that as a group at school, after they eat, they go to the bathroom and they all purge their food. So it's like a group activity kind of thing. And I heard it from many patients in different schools. So this is a major concern, and we're seeing it a lot more recently.
Thank you, Joanna. I guess the bigorexic don't come to us because it's so positively reinforced by the environment and society, and everyone is complimenting them and asking them how do they do it. So they don't see that it's a problem, so they won't basically they won't come. I agree. Maybe Dr. Iman and Madiha before, so that we have time to go through all the questions. We're going to take a couple of answers from panelists, and then we can move on. But Dr. Iman and Madiha, I'm interested in hearing you because you've been doing this for some time now. So maybe you can tell me if you see a difference.
Yes, of course. I'm not going to repeat the same. It's just more or less similar problems. But now part of my assessment is a very thorough social media
screen.
Yes, some of them, they come with gadgets and they come high tech, and they use that to go downhill very fast. And this is what a pattern I'm seeing now. They they're more precise in counting input and output calories. They come with the smartwatches. Your assessment will be very, very, very deficient if you're not aware of this stuff that is working against you.
This is so valuable and so important. So important, Dr. Iman. It's true. Very true.
Also, disordered eating. I'm seeing kids who are using GLP injection and without the consent of their parents. They get access to it and they use it, which is this is something I'm seeing now. In boys, it's a different story. I'm recognizing a new problem now: use of anabolic steroids in boys in gyms. This is something we have to be aware of it when with body dysmorphia and the culture of masculinity. This is, I don't like my body I'm fat. I want to change. I want to be muscular like the influencers and the social media.
I want to decrease my body fat percentage and increase my muscle mass, which is in itself extremely difficult from a physiological perspective to achieve. And this is why, as Romana was saying, counting macros and taking steroids and things like that.
Yes, this is something you have to be aware of it. Yes, Dr. Madiha, I think I don't want to take
Dr. Madiha.
Yeah, so from Qatar, I agree with everyone else what said early. The age is getting younger. I have an 8-year-old Lebanese boy who celebrated his 8th birthday in the hospital because he was severely emaciated. I have 2 9-year-old girls who started their eating disorder, and by the time they came to the inpatient unit in 9.5, so the ages are getting younger, and this is one of the reasons why they changed the DSM-5 criteria, which they took amenorrhea out because we were seeing more boys. And I have something like 5% of my patient population are boys. Recently, I have a 14-year-old who was told, somebody told him, if you want to get taller, which he's really dying to get tall, stop eating and lose weight. So he got eventually stunted and he was really emaciated. So I have a lot of stories to tell you about boys and younger ages. The other interesting thing, what's new in anorexia nervosa we're seeing is exactly what the speaker in the AAP said, that denying distorted body image. So the girl would walk in and say, look, no, I don't have a distorted body image, but I want to be only 40K. So this is the interesting thing. And of course, I have one of the boys who stole the Ozempic from his mom, and he was injecting himself, and somehow he imported it from Saudi Arabia, and he used it to lose weight, and he doesn't really need it. Actually, not in my patient population, one of my medical students told me, she's a medical student at the university, and she said that she went to Turkey to do sleeve surgery, part of her eating disorder, and they did the surgery for her. So, but in pediatric, we're getting younger and younger ages, denying of distorted body image, use of Ozempic, and we're seeing more boys actually in that field. That's what's new in anorexia nervosa.
Thank you, Dr. Madiha. This is so important to ask about social media, the social media consumption. And it's so important not to disregard children who are, not yet adolescents, so below ages 13 or 14, because historically we think that if they haven't hit puberty yet, then they can't have an eating disorder, but it's very wrong. So please, for the providers here, do not dismiss younger children. It's a rising trend since COVID-19, actually.
Carine, can I jump in as a parent?
Sure.
When my daughter got sick, I really underscore what you all said about early intervention, because she lost weight through actually both of us were away, and we both got a food poisoning incident. And that picked up on, she had already been starting to think about healthy eating. Within almost probably less than a month, we were in the emergency room. It happened so fast, and she was only 11. And the other interesting thing is
11.
part of the response in terms of our practice of family-based treatment was no social media. And let me tell you, kids will fight back hard on that, and it's very, very difficult. So we basically had to take away all social media almost
I
for
don't
a
allow
year. For
I
over
don't
a
allow
year.
any gadget in the inpatient for as long as they stay
Nothing.
1 month, 2 months, 3 months, no
Yep.
screen, zero
No
screen time. So
screen.
this is
And
how it
even at
started.
home. And that was really hard for parents because we did ours at home, right? After. So for parents also to get on board that, sorry, your kid will find a way to get that phone from you and will be looking up diet. So it's such a big thing to take away. You know, there's so many great benefits to AI and social media, but it can be really, really dangerous in this disorder. Over.
Agreed. Amy, to you, the next question.
Okay, so we're going to jump around as well, and maybe I'll just ask who wants to respond first. So what is the most common misconception about eating disorders that you encounter, either among the public or healthcare professionals? Who would like to jump in first on that one?
Can I say one word?
Yes, ma'am.
It's your fault. This is the most common misconception. So you can do it. A very simple disease, just go home and eat. What's wrong with you? This is the most common misconception. So among healthcare providers, let alone parents, and other than the punishment and all these things. So it's a disease. That's why I explained to the parents and the patient, it's a disease like any other disease. And it's not your fault you got the disease. It's not the parents' fault. It's for us as a team, a whole group that will do intervention and help you. Thank you.
Also, I have a thing to say that also the major misconception that they think eating disorders is related to the nutritionist role to solve the problem. Although, as I mentioned, it needs a multidisciplinary team. So, because I've often hearing parents saying, "Oh, Zaina, we think nutritionists are the only source of treatment that can provide the pathway for relieving from this disorder." So I always mention, which is the lacking thing in our region, is a multidisciplinary approach towards solving eating disorders. So they think just, oh, I need to book an appointment with a nutritionist. They don't know there is underlying psychological issues, also maybe anxiety, maybe depression. Also, that's always let's say misperceived, that eating disorders, that, for example, the parent saying her child suffering from eating disorders presentations, they don't know that there might be underlying trauma, underlying depression, that they need to consult a trained psychologist that will help the patient along with the nutritionist to reach to a certain point where they can be improved. So that's a very, very major misconception that's being seen here.
It's very
that
true.
makes
However,
a lot of sense.
however, the eating disorder has to be treated first. So even if we have underlying trauma and other, issues, which usually we always have, we should not think I'm going to treat the trauma and the eating disorder is going to get better alone. No, the eating disorder has a life of its own, and it needs to be targeted first, in my opinion. And then, when the patient is stable and the medical risk is under control, then we can talk about the underlying factors, because this is also a misconception. I find that, if I treat my trauma, I'm going to recover. No,
that's true.
It's not. Yes, Hannah.
Yeah.
Yes, I was going to say that also another misconception is that you can tell when someone has an eating disorder. I've had a lot of clients come in the clinic where they've seen like GPs and they've like told them their symptoms, and the GPs have told them, no, you don't have an eating disorder because you're not underweight, basically. And this is why the DSM is changing and the criteria is changing every day. But that usually delays the recognition by family members, by the client themselves, and by their mental health care professionals. And I've seen that also people kind of, in a way, they do not recognize their own struggles, or they do not validate their own struggles because they feel like they're not sick enough and they don't really deserve the help.
That seems
I
to be
agree.
really resonating with the audience. We've got a lot of people who are just acknowledging too. Dima. Oh, sorry. Did you want to follow up, Carine? Sorry.
No, I wanted to before we give the floor to Dima, I wanted to follow up on two comments on the chats, which I think are very relevant in terms of misconception. Is that it is a GI problem, right? Because especially our patients who are on the restrictive spectrum always have GI symptoms, always have diarrhea, IBS, bloating, etc. And they typically think it's a GI problem, and the parents also and the family, and they take to the gastroenterologist, and they're on tests, and they do, a lot, and they think they have a bacteria and H. pylori and all of this, and actually it might just be an eating disorder, anorexia nervosa.
Yeah.
This is a big misconception. Can you mute yourself, please, Noor? Noor, can you mute yourself? I'm going to mute her. Okay. We're going to give the floor to Noor. Okay, done. So maybe Dima, yes, Amy. We asked Dima to comment.
Regarding bulimia and binge eating disorder, a common misconception is that they are simply a matter of willpower or self-control. And regarding RFID, it's only a picky eater. It's a severe picky eating, while it's not.
Yeah, a lot of misconception there around that too. Should we jump other panelists? Dr. Iman.
Yeah, something that I found it tricky with the professionals that they delay the presentation, that they ask the patient themselves, and the patient usually they try to hide and protect their eating disorder, and they will deny symptoms. They don't make sure that the parents are aware and educate the parents about any behavior that might suggest eating disorder in certain cases. And some parents who are very busy or do not notice these behavior might take time to notice, which can cause them to come, but at a very late stage or very delayed stage. So professionals need not to just interview the patients or because they might lie about their symptoms. They have to ask collateral history, and they have to educate the parents on what they should look for.
Yeah, so true. And then I think it also very difficult for the parent and probably even some providers, because the eating disorder takes over, and the mind, when you say lying, you're absolutely right. That eating disorder will do anything to continue. And your child, who might have been a perfectly well-behaved, wonderful child, will go to all costs to be able to, that eating disorder takes over. And so separating the eating disorder from the child and treating it, it's so important. Very, very hard concept to understand. As a parent who's been through it, I can tell you it's shocking, it's very challenging, it's very scary, and you need that help and support from wonderful providers like yourselves.
Sorry, and it's more tricky when they're like a student, very intelligent.
As they usually are.
Absolutely.
As they usually are.
What happened to my perfect child? Remember, we always hear that. What happened to my perfect child?
It's very tricky for the parent to grasp the concept of why she cannot see that this is something that's very logical, that she is wasting her life and she's harming herself.
Absolutely.
And that's caused lots of delay, because they think that she should be like snap out of it or fix it.
So right. So right. And I think too, when you all mentioned the trauma piece of it, is that a lot of the trauma is caused by the eating disorder. And those, if it persists for years. And I also, one thing I also always tell parents is that your child will come back when the brain is renourished. And, my child is 24 now, doesn't even remember those years, and it's very, very, it's a real marathon, but we try to give a lot of hope that your child will come back with health. And this will all be an amazing learning experience, a very scary one you never want to go through again. But okay, let's see who else. So Jumana, did we hear from you on this one, the most common misconceptions?
I think all of the misconceptions that were mentioned, I see them a lot, but also something I hear a lot from parents, it's just a phase, it will go on its own. And they don't realize that it actually needs a lot of work. And it's not just something you do, you go on a diet and then you come back. No, it's a really big problem that requires a lot of help and specialized care. So this is something that I also had to work with some pediatricians on, because a lot of times I hear that parents bring in their children and the problem has been there for a while and they've been following up with the pediatrician. So when I ask them, they tell me the pediatrician said she'll outgrow it. So this is something not just with parents, but also sometimes with pediatricians. I think it's getting better, at least in AUBMC. I'm having a lot more referrals from pediatricians very early on, which is amazing.
So I think we can jump on that, Amy, to ask, what are the positives before we talk about what you hope for, but what positives have you seen, in the last couple of years, which improvements in eating disorder care and prevention, and just following up on what you said, Jumana.
So I will follow up on it. So there's lots more awareness. So I'm getting more refers from pediatricians. I'm being called from different schools to give talks to the students, which is amazing. So it's receiving a lot of attention recently. So awareness is definitely much better. And also parents have been more receptive to being involved in treatment. For a while, we used to get a lot of resistance from parents. So we include them in all kinds of therapies with children or adolescents, not just with eating disorders. And I think they're becoming much more aware that they have a big role to play and they're being more cooperative. At least I'm finding it much easier to work with the parents now because I think of the awareness. So this is great.
That's great. That's great. Our other panelists, would you like to share what have been the improvements?
Yeah, I was going to say something very similar. I've also noticed like an increase in referrals and help seeking overall. Like many factors contribute to this. I also believe that it reflects a growing awareness amongst parents, schools, like you said, and also healthcare professionals. I've been personally also invited multiple times for workshops and awareness sessions in schools or universities, focusing on eating disorders or body image and early identification. So I think, this increases the referral, definitely.
Also, I want to mention, following up on everything was said, I always see the raise of awareness, as they said, on the nature of what are eating disorders, even raising awareness on the topic itself. That's number one. School nutrition education, I think it's part of it, because when we say awareness about eating disorders, you always say how to prevent at least or early detect an eating disorder. So what I've seen recently is of course, the school need for raising awareness about the health relationship with food, improving positive body image. And as Jumana mentioned, the parents are more now willing to promote the body image positivity in their children, rather than what we used to do in the Arab culture. We have this like labels and let's say body shaming phrases that we've been in the culture for so long, and now parents are more aware of how to use the body language, let's say the body phrases with their children, which I think it's very important to raise awareness as dietitians and nutritionists, to raise awareness about how to use the words when talking about their children's bodies, because I think managing the triggers as well is also part of managing part of the eating disorders awareness pathway, along the nutrition education and the development of a healthy relationship with food, which I think all in all will raise awareness more on the topic of eating disorders and the nature of it, and how actually the treatment should be within the multidisciplinary approach.
Fantastic. So you're so right. 100%. Thank you, Zaina.
Thank you.
Maybe Dima, you want to share your positives? Is the... I ask you to unmute, Dima.
Okay. In which questions? I'm a bad student.
No, the positives. Which are the positives? I mean, we're going to talk about your hopes for the future, but what have you seen as a positive evolution in the eating disorder field or with your patients? Is there anything shifting or not for you?
Yeah, there is an increase in the awareness regarding eating disorders among the public and my clients. I'm trying now to access schools to make more awareness about eating disorders, and I'm visiting more doctors to explore what they are knowing about eating disorders and to discuss with them about eating disorders, and a lot of doctors they don't know about it or hear very few informations about eating disorders, so they get enlightened with about eating disorders. So the awareness is the first step that we can move forward to know to treat eating disorders actually.
Thank you, Dima. Thank you very much. Anyone would like to talk about it before we move on?
So awareness programs are really good because it brings early identification of the disease. So early identification has better prognosis. Late presentation have worse prognosis, and it's a long journey. From our patient perspective, the inpatient, we see good outcome. This is what I want to say. So our children, when we are identify them early and they have a very good family support, part of what we do from FBT. So when they have a very good family support, we train parents what to say, what not to say, and how to share information, how to support that child. They do develop good prognosis later on. So I want to say that because a lot of parents come in a desperate situation. The children are really emaciated. Vital signs are not unstable, so are very unstable. Bradycardia, hypotension. So really, they're sick patients when they are admitted to the inpatient unit. We work as a team, a month or two, and some of them 3 months. Some of them takes more than 90 days to improve and develop this good relationship with food and be able to go home. However, I want to say the outcome is good in more than 80% of our population, in the pediatrics population.
That's great. One step at a time. Dr. Iman?
Yeah, lately I'm feeling I feel more support by my colleagues. More people are interested in eating disorder. Probably maybe somebody will be specializing in eating disorder, and will in the next couple of years will have more and more expert in Kuwait in eating disorder. And so kids will have, families and their loved ones can have access to evidence-based care. I have hope for the future in the next couple of years. Things are changing, and also thank you. That's part of it, the association for the Arab, and this meeting and the other and the conferences has a big role in doing that. So that's
Thank you,
hope.
Dr. Iman. Thank you very much. Amy?
I was just thinking, Carine, I wonder, our last question is, a really powerful one. And I'm wondering if we could take a couple of questions, and we can do it kind
From
of
the
as a quick round.
audience. Yes,
Yeah,
yes,
let's maybe
from
if
the
we have any
audience.
question. And there was one I wanted to raise to your attention. And so folks, get ready from the audience, and you can also ask questions of Dr. Carine or Hala as well. But there was one question around
FBT.
yes. Do you want to take that one?
So again, I have to say I'm a CBT person, CBT specialist. However, when we work with the younger population, we use FBT, and we've used it even before. I mean, I've been working for 22 years. We didn't know it was FBT, and we used to enroll families because we had no other option. Some families cannot do FBT. This is the problem. So it's very, very difficult. It's very taxing. It's a full-time job. And some people don't have the psychological resources to do it. Some families are disconnected. Some families are, functioning on a single parent that is working full-time and cannot take, a leave from their work to feed their children. So it is definitely the first line treatment for children, and when you can have a functional enough family to do it, it works. However, our obstacle has been to really, be able to find families that can provide this type of support. But in terms of the cultural part, I think FBT is perfect for the Arab population because, families, we still have family meals. We still eat together independently from the eating disorder. In the structure of the Middle Eastern family, until now, even though it's worse, but still, we still have family meals. We still have a Mediterranean diet. We still have parents who are very much in tune with what their child is eating. And we still have a lot of at-home moms, which is maybe different from the West. So it works from a cultural perspective. I think our culture works for FBT. I don't know if anyone has any different opinion.
Any of the other panelists or Hala?
I agree, Carine. When we work with children, you need that family support. I mean, having said that, there are patients that they don't have a good family support, and we struggle, they struggle, and they stay longer in the hospital. I mean, good news, the hospital affordable, very affordable prices. And if it wasn't for like the current patient that I have right now, limited income family, so the social services will help out. But the family support, FBT, is the main therapy. We train parents, and whenever they're ready, and some of them, they don't get ready in 1 month, maybe 2. Whenever they're ready, we simulate the meal time in the hospital before planning discharge. We send them home a week later. If that is successful, that first step successful, then the second step is to go home for 1 meal. Let's do lunch or dinner, whatever suits the family. If that was successful, then we gradually tailor it down. So FBT is the main, and you definitely need a family support in pediatrics.
So I agree with you. However, I need to stress that when FBT is not available and you don't have families that can offer this type of support, CBTE for adolescents is extremely effective, and we have tailored and worked on involving parents in a way that's very different from traditional CBTE, because adolescents, you cannot conceptualize whatever they're going through without involving the family. It's not possible. So the family involvement in CBT is very individualized, and this is the beauty of it. So when you have a functional family that's involved, you involve them, but in a way that they are helpers and not controllers. So also the pressure goes down, and the older the adolescent, the best it is, I believe, to empower them to make their own decision for recovery and not to do it for their parents. So I'm glad to see that we have many tools, and I think we should be, grateful that we have options, and we all need to get trained in both modalities, because there's not one size that fits all. We need different approaches for different presentations.
The
Allow me to
interesting thing you
comment
raised
here.
too, Carine, is that kids grow up, so they need different things at
Yeah.
different times, right?
Exactly.
Yes.
But the problem with FBT here, when we see it, first of all, the mom, usually mom, dad, whatever, they do have problem themselves sometimes. So to deal with the FBT, that's gonna take a long, like effort to teach the mom, to change the mom's behavior, to change the mom beliefs, and then that's gonna reflect to the kid. Not everyone, of course. I'm not just making it common, but now we're seeing it even more that the mom or dad themselves having a problem with the food and the overvaluation of weight and shape. And the other thing we see usually when we use sometimes only FBT, that the parents, the minute that child is out of the danger zone, they will start kind of withdrawal, like kind of they will put less effort, will pay less attention to the treatment because no, the child now is living and there are no critical case now. So this is the problem with the FBT sometimes. If the CBT, the child will be engaged, not even only motivated, engaged. So here where the child want the therapy, want the recovery, they understand the impairments that are caused by this eating disorder. They will understand the psychopathology, the maintaining mechanism. So I worked with both. I still feel in critical cases, medical instability, definitely most of the cases FBT. But if there is normal cognition and medical stability, CBT wins, because even whether the parents are available or not, but the child can be empowered, especially with this ambivalent generation.
Yeah, I agree.
Thank you, Hala.
And you
Thank
sort of
you.
touched on briefly some of the issues that you all face, and families like mine as well, with genetic predisposition. And so you're going to uncover, once you start the treatment with the child, you uncover a lot of other things. I
And a
see
lot
one
of the
question from
journey of the children, a lot of the parents tell me this has also been my journey. So a
so
lot of
much.
the parents who have disordered eating and problems with their own bodies, when they're supporting
Mhm.
their kid, some of them, not all of them, it's their own, journey of healing. I don't know if you can agree with that,
Absolutely.
but
Yeah, it's I just from a point of it's fascinating. I learned that I have a great uncle 100 years ago. When he was a priest in China, and when we looked at his medical notes, he ended up in a kind of a care facility. This gentleman had anorexia, without a doubt. And so when you look at a family history, you often will uncover eating disorders, um, and other co-occurring disorders and mental illness in the family. So I think you're absolutely right. And how is it that an opportunity that you all as clinicians can start, the healing, both the trauma, but also the actual mental illness, I think is so powerful. And you're all on the cutting edge. And then related to the training, I noticed one question in here. I'll switch gears a little bit.
yes.
Faria says, how do we approach for supervision as psychologists? As trainings have been expensive and demand is a lot more than the supply of trainers. What do you all think about that?
So I think you need to get the training before the supervision.
Yeah.
So you cannot
I was gonna
receive
say.
you cannot receive supervision, because supervision is going to be different depending on the modality that you're trained in. So I know there are some eating disorder training, like eclectic package. I don't encourage you to take these trainings, because you don't come out with a specific structure to follow, and sometimes we become more lost. So I encourage you to first start a training. And again, I guess I know that trainings are expensive because there are a lot of resources mobilized. However, it's worth it, because you become an expert, and then you can help a lot of people. But again, training without supervision is also limited, because you need the hands-on. So we personally, my group provides accredited CBT training with Credo, and our training is adapted to the Arab population, and we also provide supervision. But we don't provide supervision just for eating disorder cases, because we work according to a specific protocol. So this is me. I don't know if anyone else, I'm not aware of anyone else who provides just supervision. But again, my advice is training. And We also do provide, we're going to start providing CBT AR training, so training for CBT for ARFID. And we need to work on adapting also FBT for the Arabic population. Hopefully, this is a project we can start. Dr. Madi had discussed it with me. Amy suggested it. I think it's also important, and it should be something that we do eventually as well.
You all are really on the cutting edge here. I mean, you're going to make such profound change. You're already doing it right now. It's so exciting.
Thank you.
And
Thanks
as I
to you,
mentioned
Amy,
earlier,
as well.
well, at the top mentioning, while you're focused on the Arab world, this is pertinent for any place that has underserved and it needs an adaptation from the Western model. Yeah, so important. I'm wondering, maybe we could take one more question. Anybody from the audience have anything else? You can feel free to
Yes.
come off mute rather.
Yes, come off mute and there was a comment on neurodivergence, and I agree that neurodivergence is something that we see also more and more in the new presentations. Fariha, please put your camera on if you want, and you can unmute yourself, obviously.
Thank you for the very, very wonderful, informative webinar. And thank you for making it free as well, because a lot of these things have been expensive lately. So I really appreciate this being so
Thank you.
informative and approachable, actually. You guys are so approachable. Thank you so much for that. And thank you for answering my previous question. So I'm a newly licensed psychologist working in Dubai, and I've been lately very interested in working with somatic therapy. And I wanted to also know how useful would that approach be with treating eating disorders. I'm also someone who has suffered with an eating disorder in my teens, and that makes me want to help people with eating disorders a lot more. However, just me, and this is just my experience of it, that approaches like CBT have not worked for me a lot. I have worked with nutritionist coaches who have tried CBT, also psychologists who have tried CBT, and I felt like I needed a more layered approach, because a lot of my eating disorder, just for me personally, came from childhood, and I just felt like a more layered approach and a more deeper approach was important for me. So if you have worked with somatic work or other approaches that could cure or treat eating disorders, what would that be? And yeah, that's my question.
So there is no evidence that somatic approaches work with eating disorders. However, there are other approaches other than CBT and FBT. There is a very, very, there's a great therapy called mantra. Mantra is the Maudsley approach for basically adult eating disorders. So I don't know if you're familiar with the Maudsley approach. So it was Janet Treasure at the Maudsley Hospital, and it was like, it's called the new family-based treatment. So it's basically coaching parents to support children from a slightly different perspective than FBT, even though it stems from the same hospital and the initial same training. And they have adapted this to adult treatment, and it's called the Maudsley approach for adult eating disorder. It's called Mantra, and so they do provide trainings in the UK. The Maudsley Hospital, the IOP provides training on Mantra. If you want, I can send you the contact of the group, and you can contact and see when is the next training. It was I took two of them in person. It was in the UK. I don't know if now they're doing it online, but there are other approaches. So Mantra, there's another one called SSAM. SSAM is from New Zealand, and it's a specialist supportive approach. So it's more coaching. It's not CBT. It's more coaching, and it's more practical, on the ground, on daily basis kind of coaching. SSCM. So this is for anorexia as well. Mantra is for anorexia as well, and these are the evidence-based treatment: CBT, FBT, and Mantra, and SSAM. Now, I don't know if you're familiar with DBT. DBT also has adapted its protocol for eating disorders. So there is something called radically open, RODBT, which is adapted for anorexia nervosa. So it's a specific protocol of DBT that is used for anorexia nervosa. So DBT is about emotional regulation, and RODBT is about, on the contrary, working on the control. So it's radically open, and it's also, it has good data, so it's promising as well. So there are other approaches. Hannah, you wanted to say something?
Yeah, I was going to say also DBT skills for binge eating and bulimia nervosa. I feel like it has been studied a bit as well. So I think she can
Definitely.
also explore that. Yeah.
It's very useful, and actually I invite you all to meet us at our next eating disorder conference, where we are inviting Dr. Basma Kilani from the DBT group in the Middle East. She's the founder of the DBT Association, and she's going to give us a talk on DBT for binge eating disorder. So absolutely.
Dr. Carina, I think you all need to do many more sub-sessions after this. There's so many important things. We're going to do a quick, we have 2 minutes left, 1 minute left, and we're going to do a quick round and ask our panelists, and then also Dr. Carina and Hala, if you could change one thing to improve eating disorder care in your country over the next 5 years, what would it be? Let's start with Dima.
Dima is away.
Dima?
She had to jump off.
No problem. Let's go maybe Hannah.
Yeah. Can you hear me? Yeah.
Yes.
I was going to say to improve early recognition mainly of eating disorders, and also expand access to specialized treatment in Egypt specifically. So it means better training for healthcare professionals, greater public awareness, and more structured treatment options.
Beautiful. And Jumana?
So you said one thing. I would basically focus on training that is evidence-based for more specialists across Lebanon. And if I'm allowed to dream, maybe establishing a residential facility somewhere in Lebanon, starting off for ED patients, because this is much needed. But I think I said if I could dream, because I think maybe that needs a bit more than 5 years. Let's start with training professionals first, and then going
Dream
there.
big, though.
Jumana, you have the ability at AUBMC to do a stepped level of care. You can do intensive outpatient.
Yes,
so you have
available.
A day program already available, and hopefully you can, I'm always pushy, but hopefully you can use the format for your eating disorder patients.
This is definitely a plan. The problem now with all the situation, every time we start, we want to do something happens again. We're in war, the financial crisis and everything. And don't forget, Carine, Kamen, for example, 3 sessions with me equals the minimum wage in Lebanon. 3.
Oh gosh.
So the barrier is really big for actual change. So there's a lot of financial burden on patients. So, but it's in the plan, Akid.
But it is in the plan, right?
Yes, of course. Yeah.
Wonderful.
Zainab.
Iman. No, sorry, Iman.
Sorry.
Raised her hand.
Iman's next. Sorry, Iman. Sorry, I can't see the screen.
Yeah, for me, it's not work hard, work smart. So my next project with my colleagues in the Gulf area, with my psychiatrist, child adolescent psychiatrist, we are planning to put guidelines and for the social media and the digital ecosystem. Because instead of spending our life, we'll never have enough specialists. We'll never have enough specialists. We'll never have enough resources. But we can do something in prevention and go back to basics and mental well-being, good sleep, activity, good relationship with food and good diet, and then this is the thing is like guidelines of how to have a healthy. Kids are raised in a healthy digital ecosystem that gives them benefit more than harm, and protect them.
Yeah. Thank you. We should collaborate, Dr. Iman, because we want our goal is policy making and regulation and things like that. So we can definitely discuss at another moment.
Definitely.
And we have who next?
Zaina.
Yes, Zaina, then
Yeah.
Madiha.
So what I think the major thing that I would change is working hard on the early detection and early screening for eating disorders by raising more awareness among physicians, psychologists, of course, that they have the suitable training, because that I believe early detection is actually number one factor for long-term recovery. So what would I work on that exact aspect, which I think will lead to so many good outcomes and long-term recovery.
I love that. And then Madiha, and then Hala, and then we're going to close out with you, Carina.
So I agree with everyone else. Awareness programs for healthcare providers as well as community, school children, more resources, training, manpower, and residential. Thank you.
Awesome. And then Carina, can we ask Dr. Hala to give her
Of
number
course,
one?
and then the closing will be by Carina. But
the other
yes,
Carina.
the other
Carina and
Carina.
Carina.
But Hala, tell us about the UAE.
Yes, my only now, if I can change now something immediately, is the raising the awareness among medical staff and medical team, because gynae, pediatrician, gastro, they do give sometimes very triggering and misleading info, like PCOS go low carb or no carb. I don't know what go gluten free, and this is all eating disorder triggering, and without knowing even the history of the weight, you just go lose weight. So I would definitely start with raising the awareness among medical field, and then I'll go there. If there is something now I can change, is definitely the doctors and the medical field more than any other thing.
Thank you. Thank you very much. We will close, Amy and myself. However, I'd like to give Carina 2-3 minutes to talk about our association and how you can all support us. Because if we're all here, it means we all have the same mission at heart and we have the same interests. Carina, the floor is yours.
Hello, everyone, and thank you so much for being here with us and for our first event, which I believe was really successful. A lot of people came in, lots of engagement, lots of diversity also from practitioners. So I'm really, really glad, and thank you for everyone for having participating in it. I'm talking about you, Amy, Hala, Carine, and everybody. So really, AIDA stems from a dream that all of us different clinicians working in the field have. We all want to raise awareness about eating disorders. We all want to provide awareness, education to our population, to our clinicians. Like Hala said, there's a huge need to reach out to medical field and healthcare professionals for them to know about eating disorders, because they are on the first front. I would even add personal trainers, because I believe as well they can have a big impact at identifying eating disorders or not. So AIDA really is here as a platform to provide this education on our social media page, which we started now with Instagram. We have the future plan to have other platforms, hopefully, and we have our website as well. And we have been adding on our website all our resources, all our educational resources. There's a directory of help as well, where we added all the different countries of the Arab regions which have access to care. And all the beautiful panelists today are part of our directory of help. So whoever is struggling with an eating disorder or think they might be struggling with an eating disorder, they could have access on our website to an easy questionnaire to see if they might have an eating disorder. For example, they can have the resources and check out a lot of different information. And if really they are struggling, they could have access to the directory of help. How you guys could help us? Well, first is to raise awareness about AIDA. Make AIDA out there in the public world know that we exist. We are very new, so our social media page is new. We need more followers. You know, the algorithm of Instagram is not really easy. So the more we get likes, the more we get shares, the more we get engagement on our post, on our reels, that will help us have more visibility. If you guys would like to contribute to content, to reels, also you can reach out to us via our email,
I'm gonna
ida.info.aida.
put all that in the chat. So the Instagram is Aida
Yes,
Middle East,
Aida.
and the website is www.aida.me, and the email is info@aida.me.
Aida.m. Yes. So you can tell us how you could contribute to content creation, to reels creation. Maybe we can also collaborate with one specific country where we can do some webinars, such like on a smaller scale, or such this one. So I guess we can really try to do better and to eventually help more our region, because everybody deserves care.
Thank you, Carina. Thank you.
Thank you.
Wow. Okay. So I think that's a wrap. Thank you,
That's a
everybody.
wrap.
This has been so
Thank you.
great.
Thank you. Thank you, Amy. Thank you, all our wonderful panelists. I'm so happy that we had people from, all over the region. And hopefully next time we'll have more representing more regions in the Arab world. Thank you, Amy, for involving us in this important event. And we hope to see you all very soon at our next event. Have
Bye,
a lovely
everyone.
day, evening.
Bye-bye.
See you soon. Bye.
Thank you. Bye.
Ciao. Bye.